Good evening, everybody. Thank you for joining us for our Death with Dignity webinar tonight. Just a couple of housekeeping things before we go ahead and get started. This webinar is being recorded, so it will be posted to the Redington-Fairview YouTube channel if you would like to share with anybody or watch it back at a later date. The chat feature is disabled for webinar purposes, but we do have a Q&A option. You can find that at the bottom of your screen. Feel free to submit any questions that you may have for our speaker throughout the training, and we will get to the Q&A at the end. My name is Brittany Dunphy. I work at Redington-Fairview General Hospital, and I will be the moderator and facilitator for this evening. And I will pass it over now to our speaker, Val.
Thanks very much, Brittany. It's really an honor to be here this evening and to spend time with everyone. I am going to go ahead and share my screen, and then we will get started. Just a couple of housekeeping items. Like many of you, I live in rural Maine, and I sometimes experience interruptions in my internet connection, so I am hoping that will not happen this evening. If it should happen and the webinar locks up, please just sit tight. I will be able to log back in within a minute or two typically. But again, I hope that doesn't happen this evening. So my name is Val Lovelace. I am the Executive Director of Maine Death with Dignity. I was the grassroots leader and organizer for 3 legislative sessions, working to pass the legislation that we are now fortunate enough to have in Maine. The Maine Death with Dignity Act was implemented in September of 2019 and has since been serving the needs of terminally ill folks who want to choose this option. So the first thing I would like to let everyone know about is that medical aid in dying in the United States is a palliative care end-of-life option that's now available in 12 U.S. jurisdictions, but is perpetually the subject of confusion and a lot of false information. So I encourage you, if you are going to go to the internet to try to find information, to make sure that you vet the information you receive, because it is possible that you could come across information on the internet that is not fact-based. And I would really hate for you to find information like that and think that it's true and that it's serving your needs when in fact it might not be. I will give you a couple of websites that you can go to that you can trust the information on. So if you've got some writing materials handy and want to jot those down, that'll be in a couple of slides. So tonight we're going to talk about the term death with dignity in the context of U.S. legal and medical practice, and I'll clarify the circumstances under which people can access aid in dying here in the United States. Sometimes it's really tempting for me to go off down the rabbit trail and talk about the laws in other countries, but I don't want to do that during this session, and the reason for that is I don't want you to leave confused about what applies in the United States and what applies elsewhere. So unless I specifically say I'm talking about another country's law, everything I discuss this evening will be in the context of U.S. legal and medical practice. We'll talk about and clarify other terminology that gets used in relation to aid in dying laws and how some of that is appropriate and some of it's inappropriate. And then we will identify the legal and medical requirements for patient qualification, not only in the U.S. in general terms, but specifically here in Maine. So a couple of websites you can go to for more information. The first is maindeathwithdignity.org. Don't forget the Maine part. We are a 501c3 donor-based organization. We work independently of any of the national organizations. And you can go to our website for Maine-specific information. And then the other website is the Academy on Aid in Dying Medicine. Their website is aadm.org. That organization was founded by a physician in California about 5 years ago, really for the purpose of supporting clinicians and those involved in helping patients with medical aid in dying. But you can access the law and any kind of information you want via that website to get more clarity around specific things like ethics or pharmacology, patient support, and so forth. So I encourage you to visit both sites. The other two national organizations, deathwithdignity.org and Compassionate Choices, you can also find fact-based information on their websites. So I'll just give you a minute or two to jot that down. Again, that's maindeathwithdignity.org or aadm.org, the Academy on Aid in Dying Medicine. So I want to switch gears and talk about first the legal definition in the United States for aid in dying, and that is the prescribing of a single dose of medication that a qualified patient will self-ingest. And every place on this slide you see an underlined phrase has a lot of legal and medical context and some history behind it that we'll unpack this evening. The medication, of course, is dispensed in a lethal quantity. The purpose of it is for a patient to take that medication to hasten their death. It's written by a consenting physician, meaning that no physician is required to practice aid in dying medicine, just like no physician is required to become an ear, nose, and throat doctor or a surgeon. So it is really up to a physician to decide for themselves if they want to practice aid in dying medicine. The medication would be dispensed at the formal request of a qualified terminally ill adult patient. And that has a lot of stuff to unpack that we will do tonight, both in terms of legal and medical context. And then it follows a legally defined standard of care process in the state that has the law. The only exception to that is the state of Montana. They allow the practice of medical aid in dying, but it is not, there's not a statute recorded in the law books in Montana. That was actually by their state Supreme Court decision, and I'll talk a little bit more about that in just a moment. All of the other U.S. jurisdictions do have statutes in place that authorize the practice of aid in dying medicine. So I'm going to switch gears now and talk about the medical definition because it varies significantly from the legal definition where we cross the T's and dot the I's and we refer to the statute for some very specific language. But really, medical aid in dying is a clinical practice. It's a palliative care practice that involves ongoing clinician evaluation and care for a terminally ill patient who is considering and potentially will follow through with hastening their imminent death through the use of medications prescribed for that purpose. This definition comes from Lonnie Shavelson. He's a physician out in California, and he founded the Academy back in 2020 with the vision of ensuring that there would be a high standard of practice, consistent best practices among clinicians, regardless of which state they were in. And in fact, the Academy now publishes an annual journal. They have an ethics committee where clinicians can write in about specific cases or case details to try to help them wind their way through ethical questions. They have a lot of training tracks available if you're interested in that, whether you're a death doula, a clergy person, a nurse, or a physician. And there's probably around 1,400 to 1,500 folks now involved in supporting the Academy's work. So aid in dying is really the practice of medicine. It's the practice of palliative medicine, and it's not just about crossing the T's and dotting the I's and qualifying a patient, though that certainly, the legal framework certainly is a part of that best practice. So currently, aid in dying is an option that's available in 12 U.S. jurisdictions, the most recent of which is Delaware, which was just signed into law. Their law will take effect after their Department of Health and Human Services implements some structure around that. So the first state was the pioneering state of Oregon, who in 1994 initially passed by citizens initiative. At the time, many other states were trying, including Maine. I think our first bill was attempted in 1993. So by citizens initiative in 1994, it passed. And at the time, the federal government took offense to that, and they tried to intervene and stop Oregon from implementing their law. So they went to court. 3 years later, Oregon won, and lawmakers in Oregon put the issue back to the ballot, hoping to overturn the law, but Oregonians passed it by an even greater margin. So their law went into effect in 1997. It was a full 11 years later before another state passed aid in dying legislation, and that was the state of Washington, also by a citizens initiative. And then Montana followed. Montana's allowing the practice of medical aid in dying came about as the result of a lawsuit that was brought by a terminally ill patient and his physicians. And what this patient asserted to the state was he had a right to the protection of his dignity and his privacy under the Montana state constitution to access medical aid in dying, and that his physician had a right to practice medical aid in dying. So that lawsuit went all the way to the state Supreme Court, and while the state Supreme Court did not agree with him, meaning that their state constitution did not guarantee that, what they did say was that on review, there were no statutes in the state of Montana that would prohibit the practice of aid in dying. And therefore, in the absence of a law that says you can't do something, you can do that thing until somebody passes a law that says you can't do that thing. And that's how it sits in Montana. So the challenge for Montana is, of course, every legislative session, some lawmaker will try to pass a bill that will prohibit the practice of aid in dying. That bill was just defeated recently again in Montana. They face that every legislative session. And of course, the other problem is they don't have a statute, and therefore there's not a lot of public knowledge or information about aid in dying medicine in Montana. And so if practitioners don't know that they can practice it and patients don't know they can access it, it's a pretty rare thing in Montana. In Vermont passed in 2013, and for the first time, there was a state that passed by legislative action rather than by a lawsuit or by a citizens initiative. So that was a 10-year campaign in Vermont before they finally got a bill through the legislature, meaning the House and the Senate put their heads together. They sponsored a bill through. It went to their governor. The governor signed it into law. And that sort of set a model for the rest of the states to follow, that this was something that lawmakers could listen to their constituents, could understand that the people in their state wanted this law, and they could do it legislatively rather than by citizens initiative. Not every state has the option for a citizens initiative, and so this makes legislation possible even in those states that don't. California followed very quickly on the heels of Vermont in 2015. Colorado had a citizens initiative in 2016 that passed by 67% of the popular vote. And then Washington, D.C. passed by city council vote in 2017, followed by legislative action in Hawaii in 2018, and then for the first time, 2 states in 1 year, and that was New Jersey and Maine in 2019. Shortly after that, the pandemic hit, and that put all routine legislation on the back shelf while states turned to handle the emergencies of the pandemic and emergency lawmaking and so forth. New Mexico came back in 2021 with their bill, which passed after a 25-year history of attempting to pass legislation in that state. And then, as I mentioned, Delaware is the most recent state to come on board. Nevada also passed in, I think it was 2023, but their governor opted to veto the bill. That also had happened in Delaware, so it's nice to see Delaware come back yet again and finally join the ranks of those states that allow the practice. You'll see off to the side of this slide a couple of red arrows and some dates, and I just briefly want to address those because I think these are events that acted as catalysts in the public domain that really help us be willing to have these kinds of conversations more openly about the ways we die in the United States and how we can best meet people's needs. The first was in 1999. Some of you may remember a physician by the name of Jack Kevorkian who lived in Michigan. He had devised a contraption that his patients could use to deliver medication to themselves to hasten their death. And prior to his active participation in the death of a patient, while he was certainly a very controversial figure, he had not run afoul of the law until he actively participated in the death of one of his patients, meaning he pushed the button that delivered the medication rather than the patient themselves doing that. There's a fundamental difference there between one person causing the death of another, even in a legal environment that would be considered euthanasia if euthanasia were legal, and medical aid in dying where the patient themselves makes the decision and takes the action to take the medication. So Kevorkian was arrested, he was convicted, and he went to prison, and he died shortly after getting out of, I believe he had a 10-year sentence. If we fast forward to 2014, some of you may have heard of a young woman whose name was Brittany Menard. She was 29 years old, and she found out shortly after her honeymoon that she had a glioblastoma brain tumor. I believe California had a citizens initiative in 2013, and when that initiative failed, Brittany talked to her husband and her mom, and she said, I want to move to Oregon, and I want to establish my residency and my health care there, and ultimately I want to avail myself of Death with Dignity in Oregon. Her husband and her mom supported her decision. They picked up hearth and home and moved to Oregon. And on the 1st of November 2014, Brittany used her medication with her husband and her mom by her side. Um, Shortly before her death, she recorded it's about a 6-minute video you can find on YouTube if you just search for her name, Brittany Menard, Maynard. And in that 6-minute video, she talked about why it was such an important decision for her and what it meant for her to have the option of aid in dying if she wanted to use it, and what it meant to her to have the support of her husband and her mom. That video went viral pretty much overnight across the globe. I think it has over 12 million views now. And it really sort of opened up this conversation in a public way yet again, so that, you know, folks like you and me can have conversations and can talk to our lawmakers and talk to our physicians and really demand the kind of care that we want at the end of our lives, so that we can get our needs met when we're dying. So this slide is an excerpt from the 2023 Oregon Death with Dignity Act data summary report. The lawmakers who drafted that law had the foresight to require the state to publish an annual report with demographics in it so that people could understand the kinds of people who were accessing the law, the numbers of people, what kind of diseases they had, what age bracket they fell in, and so forth. So Oregon now has around 28 years of data that every state since Oregon has used to help their lawmakers understand basically the essence of the law and the kinds of decisions that drive people to use medical aid in dying. What this slide shows is that since the very beginning in 1998, approximately 2/3 of the people who receive a prescription for aid in dying use it, and about 1/3 don't. And it's kind of a simplistic view, but what it really means is for that 1/3 of the people who do not use their medication, there are a variety of reasons for that. First of all, use of the medication obviously is patient choice. Some patients find as they're entering hospice and they're approaching the end of their life that they just don't feel the need to use it, and they feel like the standard palliative care practice with hospice is meeting their needs sufficiently. Other patients may wait too late to make a decision to use it, and by the time they realize they really want to use it, they actually don't have the physical strength to be able to do that, or they may lose capacity to do that, meaning they, in the course of their illness, they lose part of their decision-making ability, or their decision-making ability becomes impaired. And once a person reaches that point, they can't use the medication. And others sometimes choose not to use it because it becomes a controversy within their family unit. So I've seen all of those scenarios here in Maine. It's a very unique situation for each patient and whether they choose to use their medication, but it is entirely up to the patient to choose or not choose to ingest the medication. Some of the characteristics that the information that Oregon collects help us understand really the kinds of people who are accessing medical aid in dying. So out in Oregon, it's slightly more than half of the patients are male and slightly less than half are female. Here in Maine, we actually see the opposite. We only have 5 years of data right now, so it's not a huge amount of data to suggest any kind of a trend. But overall in Oregon for the past 26, 27 years, it's pretty consistently slightly more male than female, but relatively split down the middle. Age brackets, as you might guess, people over the age of 55 you look at the numbers of people over the age of 55 and you see that the majority of people who ingest the medication are in that age group. And that's because that's when our bodies start slowing down and we tend to suffer from more chronic illnesses. There are, of course, some younger people who are unfortunate enough to contract a terminal illness early in their lives. Brittany's data is in this 18 to 34 bracket, but by far and away, most of the folks who ingest this medication are over the age of 55. This slide I find pretty interesting. In Oregon, 96% of the people who access aid in dying are Caucasian. And that would not be unusual if that was a reflection of the overall demographic of Oregon, but it's really not. Oregon is about 74% Caucasian, and all things being equal, we should then see approximately 74% Caucasian using aid in dying, and then lesser groupings or smaller groupings of people who are not Caucasian also accessing the law. But we don't see that. There's been some conjecture around that. Some people float the idea that maybe it's a cultural thing, that, people of European descent tend to be more individual and wanting to make decisions on their own, whereas non-Caucasian people may be more culturally influenced and so forth. I think that's a real stretch, and I think, truthfully, we'll never get to why this is. But for me, with the rest of the data on this slide and the next slide, it suggests that there's a certain amount of privilege that goes with being able to die in this way. And what I mean by that is if you don't have enough resources or enough financials or a way to have access to high quality health care, you can't actually access medical aid in dying. So if we look at the kinds of folks who are accessing it, by far and away, the largest population has at least a high school education and higher. And even if you take out the high school graduate or GED level folks, we're still looking at around 75%, 74% of the folks have some level of college education on up towards professional degrees. And while that in and of itself doesn't mean anything other than what's shown here on the slide, there is an implication that that might lead to a better paying job or better healthcare insurance or some other way to access high quality healthcare. This slide, I think, tells the greater story about this sort of disparity in access. I'm going to talk first about the insurance, and then I will talk about hospice after that. So if you look at the overall numbers, about 38% of the folks who access medical aid in dying have private insurance, private healthcare insurance, and 61% are using Medicare, Medicaid, or some other form of government subsidized healthcare insurance to pay for their healthcare. That's the total number, but if you look over here at the more recent numbers, 2022, not quite 20% of the people had private insurance. Around 22% of the people had private insurance in 2023. Everyone else is relying on Medicare, Medicaid, or some other form of government subsidized health care, with the exception of a handful of people that there's no report on. What that means, though, in plain English is this. Back in 1997, when the federal government lost their lawsuit to Oregon, they said, fine, Oregon, you can have your law, but you'll never use federal money to support it. So a bunch of opposing lawmakers got together and they passed the Federal Funding Ban Act of 1997. And what that ban does is it prohibits the use of Medicare, Medicaid, or any other government subsidized health care, any of those monies from being used to support a patient who is seeking medical aid in dying, none of those physicians whose salaries are underwritten with federal dollars. So we're talking low-income clinics, we're talking the entire VA medical healthcare system. None of them can participate. And in fact, I'm a veteran. I get my healthcare up at Togus with the VA. My physician could not even write me a referral to see a physician, a private physician, if if they had the idea I was seeking information about medical aid in dying. So that prohibition went into effect in 1997, and that is why I think we see the numbers we see. Because if you rely on Medicare or Medicaid for your health care, you have to have out-of-pocket resources to access medical aid in dying, because you can't use those dollars for it. Not even your Advantage supplement or anything like that uh, currently can be used to support your end-of-life wishes if it involves medical aid in dying. Now, folks like you and me, every payroll, we contribute to Medicare and Medicaid, our money, our earned money, to support our use of Medicare later. So this really amounts to taxation without representation if you think about it. If you can't use your own Medicare investment to help you pay for medical aid in dying at the end of your life. There is a bill before that was introduced, I think, last year to try to repeal at least the Medicare portion of this, because rightfully each of us who has contributed to Medicare should then be able to rely on those dollars at the end of our life if we want to choose medical aid in dying. I don't know how long it takes to get a federal law changed, but my guess is it takes a very long time. So time will tell whether we can ever get that piece repealed. So that's why I think we see those numbers. And I forgot to mention the hospice piece. So hospice overall, around 91% of the folks who access medical aid in dying are also enrolled in and receiving hospice care at the time of their death. So hospice is a benefit that can be paid for by Medicare if you enroll in it and you qualify for it in terms of your income level and so forth. But again, if you want to use medical aid in dying, you can't access it using those Medicare dollars. That would be an additional out-of-pocket expense for you. Even in the last couple of years, this number remains very high, and that's because it's important to have good palliative care when you're terminally ill. And the two, hospice and medical aid in dying, are perfectly compatible with one another. They have a different focus on care, but once you enroll in hospice, the goal of that kind of palliative medicine is to help you live as high a quality of life for as long as possible, as high as possible throughout the course of the end of your life. And then if you want to augment that with a choice to use medical aid in dying at the very end, you're free to do that, but Medicare will not pay for that part. In terms of the illnesses that really kind of help people shape their decision to qualify for medical aid in dying, by far and away, the vast majority of folks have cancer, to the tune of about 70% overall. And then around 11% of the folks have some neurological disease like ALS, MS, Parkinson's disease. And then there's a smaller groupings of other diseases that ultimately, while a person can live with these kinds of diseases for a while, ultimately they result in terminal conditions that then could qualify an individual for medical aid in dying access. But by far and away, it's cancer or neurological diseases. What's important for you to take away this evening about neurological diseases is that sometimes those diseases can impact a person's cognitive ability, because these are diseases of the nervous system, and of course the core part of the central nervous system is the brain. So MS, ALS, Parkinson's can sometimes affect people and their decision-making ability or their cognitive ability. So these folks with these kinds of diseases are at a little bit greater risk of not being able to qualify. That doesn't mean that you cannot qualify. You certainly can, and I've certainly seen all of those patients, ALS, MS, and Parkinson's patients, accessing medical aid and dying over the past 5 years. But it can be a little bit more tricky if it happens to be affecting your cognitive ability. So I'm going to switch gears real quick and talk about terminology. Death with dignity, of course, was the term that was first coined back in the late 80s, early 90s. And what it meant was that a person wanted to be able to have some control over the way their end of life went. Over the years, that term has been challenged a little bit. Some folks in opposition say that it implies that if you're not using medical aid in dying, you can't have a dignified death. I think that's a pretty big stretch of the imagination. It's a term that's well known among folks who work in end of life or folks who think about the end of their lives. But it is, I think, it is less identifiable than aid in dying or medical assistance or aid in dying, simply because death with dignity can mean different things to different people, right? So while that term is certainly valid, it certainly applies. The Maine Death with Dignity Act is titled after that, after Oregon's law. The other terms are more applicable inside the legal and medical community. So if clinicians are discussing medical aid in dying, or policymakers are discussing it, or ethicists are talking about it, they're going to be using the terms aid in dying or medical assistance or aid in dying. The physician aid in dying term, PAD, was used for a little while in professional journal articles, but it really is also not very commonly used. It's primarily aid in dying or medical assistance or aid in dying. For me, I tend to use aid in dying more often than medical assistance or aid in dying, and the reason for that is that term MAID, for me personally, implies that a physician may be doing a little bit more than writing a prescription. And so if you look at the laws of other countries, those physicians are allowed to practice euthanasia, meaning they can provide the medication to their patient. So as an example, if you live in Canada, you would have a choice once you qualify to either use the medication on your own or to have your physician administer the medication to you via an IV. That option is not available in the United States. Euthanasia is against the law everywhere in the United States. And that's why I tend to use more of the aid in dying term instead of the medical assistance term, simply because one implies for me that a physician is doing a little bit more. Inappropriate terms under any circumstances are suicide, assisted suicide, physician-assisted suicide, euthanasia, and so forth. And there's very pragmatic reasons for that. First of all, euthanasia, again, is against the law for humans. This is how we manage the end of life of our animals, farm animals or pets, when they get to a point where they're very sick, but that option is not available in the United States. For physician-assisted suicide or assisted suicide, those terms medically and legally imply that the individual who has died may have had the option to go on living had they not brought their life to an end. That is certainly not true for terminally ill people who are at the end of their lives. These terms also imply that some sort of an emergency response is required in reaction to that death. So, calling the medical examiner's office, calling law enforcement, and so forth. None of those things are required for a medical aid in dying death. And that's why the law the terms. Now, when you go out on the internet and you're looking at news articles or you're looking at other websites and they're using these terms, there's one of two things happening. The first could be that you're reading a news article that is guided by the AP Style Guide. So the AP Style Guide suggests terminology for journalists to use so that everybody's using consistent terminology regardless of where they work or what kind of publication they are contributing to. That would be one case. And that's actually becoming more and more rare as journalists become more involved in reporting on aid in dying. They are tending now to switch to the aid in dying term or medical assistance or aid in dying, simply because those are more appropriate terms to describe this medication and this process. The second thing that could be happening is you are probably reading information from an organization that is institutionally opposed to medical aid in dying. So there's two kinds of opposition to medical aid in dying. One is personal, so someone like you or me who may not choose this option for ourselves. Either it doesn't fit our values and beliefs or we think it's morally wrong, but we might not stand in the way of anybody else choosing this option for themselves. Institutional opposition, on the other hand, wants to eradicate these laws and ensure that no one has access because they have greater value for their institutional values than they do for individuals who want to choose this for themselves. So when you're seeing these kinds of terms, it is likely coming from a source like that. The laws do address this. Maine's law in Section 20 specifically addresses the suicide, assisted suicide, mercy killing thing, in that it says that actions taken in accordance with this act do not for any purpose constitute a suicide, assisted suicide, mercy killing, or homicide under the law. Again, there's very pragmatic reasons for that. And this language puts everyone on notice that it is not required nor desired to respond to a medically aided death in any of the ways they might respond to these kinds of deaths. Our law also is very specific about the difference between aid in dying and euthanasia, in that it states that this act does not authorize a physician or any other person to end a patient's life by lethal injection, mercy killing, or active euthanasia. So right there in very plain English, it puts everybody on notice about these things. Every state law has language like this to protect both the patient, the patient's family, and the practitioners who practice medical aid in dying. Our law goes on to say that state reports may not refer to acts committed under this act as a suicide or assisted suicide. So this language protects the individual's death certificate from those terms. During our floor debates and public hearings here in Maine, we had people coming forward who asserted that these were the terms that should be used on a death certificate. They were in opposition to the law. They were trying to create a cloud of shame, I guess, or something, by insisting that these terms be used. But this language is in our law saying that they absolutely cannot be used for an individual's death certificate. There were also people who wanted to put on a death certificate that an individual died by medical aid in dying, meaning they wanted to be able to disclose the private decision, a medical decision of an individual. Which would be a HIPAA violation, actually. So just as a terminally ill patient who's admitted to the hospital and who dies by terminal sedation, because it's the only way to have their pain controlled, they don't put terminal sedation on a person's death certificate. You can't put medical aid in dying or Death with Dignity Act on a person's death certificate in Maine either. While Maine does not direct a physician what to put on the death certificate, it only says what they can't put on it, and that it recommends to the physician that they put the underlying disease as cause of death, just as they do in terminal sedation scenarios. Like, if I had stage 4 lung cancer, they couldn't control the pain and they admitted me to the hospital and put me on terminal sedation, and that's how I died. My death certificate would say lung cancer. It wouldn't say terminal sedation. Our law goes on to say that nothing contained in this act may be interpreted to lower the applicable standard of care for the attending physician, consulting physician, and so forth, other healthcare providers. What that means in plain English is that you as a patient are protected from being abandoned by healthcare providers simply because you want information about the Maine Death with Dignity Act, or you want to qualify for the Maine Death with Dignity Act. It would be against the law for any healthcare provider to abandon your care because you were making a patient choice. So in the very simplest of terms, these laws do two things. The first thing it does is it puts into legal code the process and the medical standard of care by defining who can access it and under exactly what circumstances. And this is very unique about the law. The law does not want to direct physicians how to practice medicine. So you're not going to find laws that tell a physician how to take out an appendix. You won't find a law that tells a CT tech how to do a CT scan. And that's because the law understands that that's what school is for, and that's what certifying boards are for, and internships and residencies and all of the things that physicians have to go through in order to practice medicine. These laws, as far as I know, are the only ones that actually direct the standard of care for physicians. So in any one of the 12 U.S. jurisdictions, The only way to practice medical aid in dying is by following the letter of the law, which clearly outlines every step that needs to be taken. And then what it does is it takes that process and it distinguishes it or sets it aside and safeguards it as a different kind of death than the other kinds of deaths where officials might need to be involved, or that there might need to be some sort of a policy or procedural or emergency response to. So if you were to contact the medical examiner's office in Maine as an example and ask them how do they recommend responding to a medical aid in dying death, they will say that they see a medical aid in dying death as a medically supervised death, just like a death that occurs in the hospital or in hospice. And that's how they would expect anybody to respond to that kind of a death. So it's expected, it doesn't require an emergency response. And these are also the mechanisms by which a patient's life insurance policy is protected from non-payment. If an insurance company were to try to say to a patient's family, well, your loved one used the Maine Death with Dignity Act, and we think that's a suicide, so we're not going to honor that policy. They can't do that. And they wouldn't try. I mean, these laws have been around long enough. They know they can't do that, but that's why this language is in these laws, is to provide ongoing protection. Even 50 years from now, this language will be in these laws to protect patients, families, and the providers who are supporting them. So I want to switch gears now and talk in basic terms about how to qualify. The first is, of course, across the United States, the patient has to be an adult. There are no provisions for aid in dying for people under adult age. Here in Maine, that's 18 years of age or older. If Maine were ever to change its legal age for adulthood, that would modify this law. The individual has to reside in Maine. Now, there are 2 states so far that have dropped residency requirements. The first is the state of Oregon. They were sued by a physician who had a practice in Northern Oregon. He saw patients in both Oregon and Washington state, which also has a medical aid in dying law, but he could not prescribe for a Washington patient because Oregon's law said that his patient had to reside in Oregon, and that patient resided in Washington. So he sued the state and basically said, this is a violation of interstate commerce laws. I'm licensed to practice medicine in Oregon. I'm licensed to practice medicine in Washington. I should be able to prescribe this medication for my patient. Oregon took a look at it. They said, you're right, we're wrong. Apparently interstate commerce was not a big thing back in the 90s. We didn't have telemedicine. We didn't have practicing physicians across state lines on a grand scale or anything like that. But it's a different medical world now. So Oregon, the legislature themselves drafted the amendment and dropped the residency requirement. Now that doesn't mean that a person from Tennessee, which is a non-medical aid in dying state, could run up to Oregon, get their medication, and run back home to Tennessee to take it, because that would be illegal in Tennessee. So there are very strict provisions around how non-residents can access aid in dying in both Oregon and in Vermont. Vermont was the second state to drop. Theirs was the result of a lawsuit from a woman in Connecticut. I believe she was a property owner in Vermont. And essentially she said, okay, Vermont, you have laws that say I'm a resident because I own property and I pay taxes and so forth. And then you have laws that say I'm not a resident. I can't be both a resident and a non-resident. So which one is it? And Vermont said, okay, you're right and we're wrong. And they dropped their residency requirement. There are also strict provisions for how people from out of state can access medical aid in dying in Vermont if they're from a non-medical aid in dying state. The challenge, of course, is that takes a lot of resources. You have to travel to either state at least 3 times to have those visits with the physician. You have to pay for and use the medication in that state, which means you're setting up household or at least residency for a little while, a place to stay, a place for your family to be, and so forth. And then you're going to be paying for the transport of your body or your remains back to your home state. So it's a pretty expensive endeavor as an out-of-stater. We have had people move to Maine to avail themselves of medical aid in dying. Some folks, if they get a diagnosis, like very recently, I met an individual who had ALS. He and his family actually moved to Maine during the course of his illness. So they had been in the state for about 2 years before he ultimately used medical aid in dying. People who have relatives here may come home to live out their final days with their illness with their families here. Um, Folks just have to be aware that it takes a little time to get here, get settled, figure out which physicians you'll be using, and so forth. So residency, at least for Maine, is not a big challenge. It's having the resources to be able to come here to Maine, set up your health care, and so forth. That's hard enough. It's hard enough to move to a new state when you're not terminally ill, but trying to do that when you are terminally ill, and have the resources to be able to do that can be a big challenge. You have to be diagnosed with a terminal disease and have a 6-month or less prognosis, medically confirmed by 2 physicians. So what this means, and this is kind of frustrating for some people, is that your terminal disease has to have progressed to a point where it would likely result in your death within 6 months if it were untreated, or if you went on hospice or so forth. Sadly, this is the medical model that we have to work with. By definition, Social Security law identifies a terminal disease as one that would result in death within 6 months. So that's the medical framework our laws have to work in. So that's the spaghetti that sticks to the wall with a medical aid in dying law. And this is a clinical assessment. So sometimes, it's rare, but sometimes people end up going on hospice, and then they graduate from hospice, and then they requalify for hospice. They also have that 6-month window. That is also based on clinical evaluation, but it is not the same kind of evaluation that would qualify someone for medical aid in dying. So it is possible to be tentatively on hospice until your next evaluation, but not yet clinically fully qualified for medical aid in dying. So that's kind of something to keep in mind. Typically, though, once you're enrolling in hospice, which most people don't do at the month mark, many people wait until very late in their terminal disease to enroll in hospice. But typically, once you're on hospice, you could then approach qualifying for medical aid in dying. You have to have capacity to make informed decisions. So this is where people stop me and they say, but wait a minute, Val, what if I have dementia? So the fact is, if you have dementia and you are terminal with a dementia-related disease, which means you will die within 6 months approximately, as best as any physician could prognosticate, you don't have capacity. You probably don't know who you are. You probably don't know your family. You probably can't remember how to feed yourself. So you cannot qualify for medical aid in dying if you are dying from a dementia-related disease. Now, some illnesses can challenge a person's capacity. So I'm sure you've heard of the term chemo brain, or you're taking pain medications, things that may, make you fuzzy-headed. Physicians are going to be very careful about evaluating every patient for capacity to ensure that a person is awake, aware, alert, and oriented to their surroundings, like they know who they are and they know what they're asking for before they'll be willing to consider qualifying a patient. If a physician has concerns about capacity, by law they are required to refer a person for a mental health assessment to determine if their capacity is a permanent problem or a temporary problem. If it's a permanent problem, meaning that a person, for whatever reason, their disease has progressed to a point where it has also affected them cognitively, then they can no longer complete the qualification process. If it's something that can be corrected by an adjustment in medications, hydration, or other things that clinicians might use to help get a person back in balance a little bit, then that process could go forward. But in no case would an individual with impaired capacity be able to qualify for medical aid in dying. And then finally, you have to have the ability to self-ingest medication. Now, when our law was going through the legislature for the third time, our bill sponsor was a retired neurologist with 30 years of medical experience and 10 years of medical ethics experience. And I asked her, I said, I know what self-ingest means legally. It means the person themselves is taking that medication into their body. What does that mean medically? And she said, so the digestive system starts at the mouth, it ends in the south, and there are three routes of access for medication. The first, of course, is if the mouth is working and the person can swallow, they would take the medication orally. If their mouth and throat doesn't work and they cannot swallow, they likely would have a PEG tube or a feeding tube installed, and they can use their feeding tube to administer the medication for themselves. They have to be the person who pushes the plunger, so they still have to have the physical strength to be able to inject the medication into their feeding tube. If in certain rare situations people lose the ability to swallow and they don't have a PEG tube and they're not a candidate any longer for surgery, they might be in a weakened state or something like that, then they can do an ingestion via rectal catheter. That is a pretty rare process. It does require some medical support to properly set the catheter and clear the bowels and everything else. And then again, the patient has to push the plunger to deliver the medication through that rectal catheter. But most folks ingest orally, and then most of the remaining folks ingest with a feeding tube, particularly if they have ALS and they've lost their ability to swallow, or they have some disease process going on in their mouth, their throat, or their stomach that would make it difficult to swallow. So the process to qualify is, this is where we're going to go back and rely on the legal definition and not so much the medical definition, though the medical definition certainly comes to play in terms of palliative care. So by the time a person has the terminal diagnosis, 6-month prognosis, they have capacity, they have the physical ability to take the medication, they're a resident, they're an adult, then they can make a formal request to their physician. So for the purposes of this slide, we're going to assume that the physician is one who practices medical aid in dying. So you're going to make a formal request, which would be then entered in your medical record. The physician will go through a laundry list of things the law requires them to go through with you, and then they will set up an appointment a minimum of 15 days after that. During that waiting period time, you would be it would be recommended to you that you go home and you talk with your family, your loved ones, or so forth. And those two physicians then would confer to make sure that satisfy themselves that you are actually terminally ill with a 6-month prognosis, that you have capacity, and so forth. So let's assume all of that goes well. 15 days later, you're going to come back and reiterate your verbal request. This again is a formal conversation with the physician, who would then enter that into your medical record. And at that point or any time afterwards, they could receive your written request. Our law in Maine is very specific that the written request cannot be dated any earlier than that first appointment. So it's going to be a minimum of 15 days after the first appointment you would be submitting your written request. The written request has to be witnessed by 2 people, only one of whom can be related to you by blood, marriage, or adoption. So that other person could be a next door neighbor, it could be your best friend, it can be your attorney, it could be your mailman, it can be anyone who is not going to benefit from your death in any way, who's willing to watch you sign a piece of paper and then sign it themselves, saying they watched you sign that piece of paper. What your 2 witnesses are attesting to is that they watched you sign the paper, that it appeared to them that you were not coerced to sign it, and that it appeared to them you had an understanding of what you were signing. So they don't have to be legal experts. It doesn't have to be notarized. It does have to be dated correctly, and the 2 witnesses have to watch you sign it together and then be willing to sign it themselves. If everything is in order, once all of this is back with the physician, that physician If they agree that you're qualified, they then have to wait an additional 48 hours before they can send the prescription to the pharmacy. The pharmacy, once they get it, it's a compounding pharmacy, so that's a special kind of pharmacy. There are, I think, 3 or 4 of them here in Maine. They have a special license that allows them to make medications. They will fill that prescription once they receive it and contact you. Most physicians will recommend to a patient that they leave the prescription at the pharmacy and not have it filled until they're feeling pretty close to being ready to use it. The reason for that is, number one, you're not paying for it unless you decide to use it, because once it's dispensed, you have to pay for it. And it keeps it in a safe place because it's going to sit in prescription form, not in filled form, in the pharmacy waiting for your decision. Some physicians may not even send the prescription in, even though you're qualified. They'll say, okay, you're qualified, I consider you qualified, let's stay in touch. And when you are feeling ready to use it, let me know and I will send the prescription in to the pharmacy. For patients who have diseases where things could go south very quickly, it is fine to have it filled and have your medication at home. But you'll want to talk with your physician about that if that is the case for you. You're going to also be prescribed 2 other prescriptions. It totals 3 tablets. Those 3 tablets are for anti-nausea and to accelerate the process of your digestive system to absorb, or to enhance the ability of your digestive system to absorb the medication more quickly. You would take those medications about an hour before taking the compounded formula. The compounded formula has 5 components in it. It's dispensed in powder form. That gets mixed with 2 ounces of apple juice, or if you're taking it through a feeding tube or a rectal catheter, that gets mixed with 2 ounces of lukewarm water. So if everything goes like clockwork, and I promise you it never does, but if it did, on day 1, you're giving your first formal request. By day 15, you're giving your second request or reiterating your request and turning in your written request. By day 17, if everything is in order, the physician can transmit that prescription to the pharmacy. So pharmacies typically have about a 48-hour turnaround period, give or take a little bit. If they get your prescription on a Friday afternoon, you're probably not going to see it until Tuesday. If the physician feels that you are in an urgent situation, they can contact the pharmacy and ask that they expedite that prescription once they get it. But that's really depends on whether they have the components in-house, how quickly they can turn it around, and so forth. What I recommend to people is this is a pretty grueling process, and it almost never gets done in 17 days. On average, I would say it takes about 40 days to get qualified, given snowstorms and physician vacations and waiting for appointments and trying to find the record that never got forwarded to the physician and all of those things that can go wrong with this process. It can take somewhere around 40 to 50 days. What I recommend to people is, as soon as you think you're qualified, start the qualification process. No matter what, whether you can decide if you're going to use the medication or not, if you think you might want to use the medication, get qualified as soon as you possibly can, and then relax. Leave the prescription at the pharmacy, enroll in hospice, and get the kind of support you need to keep your quality of life as high as possible for as long as possible. And then as you get closer to the end of your life, that's when you can decide whether you're going to use that prescription or not. That's not the time you want to try to get qualified, given it could take up to 40 days. So just kind of a reminder that 35% of the people who don't use this prescription sometimes get lost in those waiting periods because they've waited too long to try to qualify. So I'm going to talk very quickly about deal breakers. These are things that clinicians look for that would automatically stop the qualification process. Then we'll watch a very short video, and after that I will stop sharing my screen and we'll open things up for discussion and questions. So the first is a significant mental illness that is distorting the patient's decision-making capacity. That patient will not get a prescription. Now, this doesn't mean, if you were treated for clinical depression at some point in your life, or you have some sort of a mental illness that is under control and medicated and you're fine, it doesn't mean you can't qualify. What this means is if there is a significant mental illness that's distorting your ability to make decisions, then you will not qualify. In the absence of a clearly terminal disease, or it's not likely that you'll die within a 6-month prognosis, you will not get to go through the qualification process until you reach that stage where it is clinically clear from your scans, from your blood work, from your physician's experience and so forth, that you are getting closer to that 6-month prognosis. In the possible presence of an easily reversible illness with non-toxic treatments where there might be confusing or difficult symptoms, that if you were getting good health care could be resolved, you will not get a prescription. What you might get is a referral for better health care. This actually happened to Dr. Shavelson out in California. He had a patient referred to him as terminal. She was interested in accessing medical aid and dying. And when he received her records, spent time with her, did his examination, he was not convinced that she was terminal. He was more convinced that she had something that was treatable and she was just not getting good health care. So he referred her away. And lo and behold, once she was able to get the kind of help she needed, her condition rebounded and she was not terminal. So I think it's really important for consumers of healthcare, patients, to understand that the process to qualify, while it might feel grueling to a patient, it might feel like it's overdone, it might feel like there's too many hoops to jump through. These physicians are going to ensure that if you're the kind of patient who should have this prescription, that you qualify. But if you're the kind of patient who shouldn't have it, that you then get the help that you need to at least help get your situation more under control, and that you don't get this prescription if you don't qualify. Finally, of course, the patient has to be physically capable of self-administering. This was also challenged out in California. There was a suit brought against the state declaring that the state's law was a violation of the Americans with Disabilities Act because it required self-administration. I believe that went to the state Supreme Court. What the courts decided, first they decided it is not a violation of the American Disabilities Act, and then they explained why they felt that way. So by definition, every terminally ill person, meaning someone who is likely to die within 6 months from an illness, is a disabled person. So the laws do not discriminate against disabled people because it's terminally ill disabled people who access it. What it discriminates on is the ability to take the medicine versus someone else giving the medication to the patient, which is euthanasia, if you remember the earlier part of this presentation, and euthanasia is against the law in the United States. So there's no possibility within the current legal framework or medical framework for us to have a process by which a physician could assist in the delivery of that medication. Frankly, I don't see any changes in that in the United States for several generations to come if we're ever able to change that. So for now, as it legally stands and medically stands, the patient has to be able to take the medication on their own or they can't have access. So with that, I'm going to share this short video. It's about 6 minutes long. And this is the story of a gentleman named Eric Carlson. While our bill was going through the legislature, he was following it very closely with interest, and he was also learning about his own terminal illness and hoping at some point he would be able to access this if it became available. So Brittany, I'm going to ask you just to give me a wave if you can hear this once I click this red button. I just want to make sure the sound comes through and everybody can hear this.
What would you do if you knew you were going to die in a week? Maybe that question makes you uncomfortable.
Awesome, thank you.
It does most of us. Our society has a real phobia around talking about death, in planning for it, in accepting it. Maine has had a death with dignity or medically aided dying law for a little more than a year now. But people in the medical community here who have elected to participate, who believe in offering terminal patients the option to end their suffering when they are ready, are reticent to talk about it. Fortunately, one patient was not. Eric Carlson contacted me last spring when the law was being debated. He was staring down a terminal illness with an awful end. He wasn't sure he would choose this option, but he wanted the choice, and eventually he seized it. We caught up with him and his loved ones in Edgecombe last month with his self-imposed countdown ticking. How are you feeling?
Yeah, I feel pretty good now.
For Eric Carlson, the last 19 months have been a terrifying ride, one that started with numbness in his arm.
And they sent me for an MRI to see if just that, if I pinched a nerve in my neck, and it came back at just a strawberry-sized brain tumor, just right here.
It was a stage 4 glioblastoma. These tumors have tentacles that worm their way through the brain. Surgery will never get all of them.
It just came just out of nowhere that fast, which is crazy.
A devastating diagnosis for a rugged outdoorsman who jumped into wildfires out west, then ran a forestry business here for the last 30 years. Surgery, chemo, radiation, physical therapy. It was exhausting. But by summer, Eric felt better, knowing he was terminal, though not fully accepting it.
The only thing you can do is just live your life.
And he did. He took his daughters to visit relatives in Sweden.
It was no longer, oh, this would be such a fun thing to do. I hope we get to do that. It was, we're doing this.
Eric took his partner Stephanie to the Caribbean, his best buds on hunting trips, and taught his nephew how to fish. He danced and embraced the things and people he loved.
I was 100% sure in my mind, like I was the anomaly.
But cancer had other plans. This past summer, Eric started having seizures. He lost his balance, some cognitive function, and his driver's license. Another tumor had formed. More surgery, treatment, hospitalization. As Eric puts it, he was back on the hamster wheel.
You're just back in this, like, this crummy fair ride that you can't get off of.
But this time around was different. Eric was in tremendous pain. Reality closed in. The final decline had begun.
There's really no happy ending with it.
Aware of Maine's Death with Dignity law, Eric, with Stephanie by his side, broached the subject with his doctors.
I was a little bit worried when we first called that we were going to have to try to sell this. Like they were interviewing us whether they were going to give us our mortgage or not.
Nothing could have been further from the truth. He says his doctors made it clear they were supportive of whatever choice he made around how and when he wanted to die. No longer able to work in the woods, to hunt, to dance, Eric felt he was losing the things that made him him.
I don't want just days. I want to be me and do the things I want to do and be able to do. So it was clear to me then that that train was leaving the station pretty quickly.
He debated it for some time. Then one night his decision became crystal clear. It was time to stop the hamster wheel for him and for his family.
I've had a harder time picking out which hot fudge sundae to get, like it was so clear, like, this is it.
He put in his formal request, got a second opinion confirming he had 6 months or less, saw a psychologist who declared him of sound mind, completed 2 waiting periods, and then, as his decline got worse, he set a date. 8 days after this interview.
I know that it's the right decision for him. He hasn't wavered.
There's just an absolute peacefulness to it where, all my affairs are in order, everything's done, and now you can plan for the positive things.
I'm never going to really lose who he is. And all of my memories of him will be exactly who he is.
And we all just come together and we joke around and we make sure, everything is the same as it always has been.
So what do you do with your last 8 days?
We're just going with the flow so far.
His best friend helped Eric get back in his beloved skidder for one last ride, the fun kind. This was Eric's last day. Surrounded by family, he took his prescription and drifted off, one day after celebrating his 50th birthday.
All right, with that, I will stop sharing my screen. And I'm happy to answer any questions that come up if I can.
Thank you, Val. So this is a reminder to folks, if you have questions, please submit them through the Q&A feature. It should be located at the bottom of your screen. I'll give everybody a chance, maybe a minute or so, to get those in. In the meantime, I just want to thank you, Val, for that very informative presentation. It was very educational, and I'm sure going to help a lot of people, and hopefully will be shared far and wide after this gets posted. So thank you so much for being here tonight and doing this.
You're most welcome. Thank you for having me.
Thank you. All right. We have some feedback coming in, feedback from somebody just commenting on a wonderful presentation that you gave. Somebody is asking, do doctors get training on this law?
They do. They can seek that out from the academy or from other experienced clinicians in the state.
Okay. Have another question. Why do some doctors choose not to practice the law? You mentioned at the beginning that it is by choice, so I'm guessing that's what they're referencing.
Right. So some physicians, first of all, the law allows an employer to prohibit the practice. So some physicians can't practice because their employer says they can't practice, and others may choose for various personal reasons. Just like a patient would or would not choose medical aid in dying, a physician also has the right to make that decision according to their values.
Thank you. Another question, what advice do you have for patients who have a doctor who says no to their request?
They should ask for a referral to a provider who will help them. If their physician doesn't know of a provider, a referral to Maine Health Palliative Care will get them where they need to go. So by law, a physician is required to give a referral if a patient asks for it. So that's what I would do, just ask for that and to have the records transferred for that palliative care consult.
Great, thank you.
Let me just add to that. If a person is a veteran, of course, they can't get a referral, right? So the Clinicians Academy also has a referral service. If you cannot get access to a physician here in Maine for whatever reason, and you are qualified, meaning you're terminally ill, 6-month prognosis, all of those things are in place, you can fill out the patient request form with the Academy and let them know that you don't have a physician and that you need help finding one. And they will try to help you get connected here in Maine.
Another question is there an approximate cost for this?
The medication right now is $425. I couldn't tell you what a consult costs because I think everybody bills differently. We do have a donor fund that allows for the payment of the medication for people who can't afford it. The other thing is that if you're a person who is on Maine Care, meaning you have low income health insurance, you can contact your patient representative at Maine Care and request a waiver, and Maine Care may cover the cost of that medication for you.
And when you mentioned, Val, a donor fund, is that through the Maine Death with Dignity organization that you are representing?
Yes.
Okay. Perfect. Somebody is asking a question about if a patient elects to do medical aid in dying, does it affect life insurance payments?
It does not in any way.
Okay. Give another few seconds for any final questions coming through. Another question has come through asking if there is any concern that we could lose this right, assuming that the person is asking if there's a chance that the act could be taken away or appealed in Maine.
So like any law or any privilege that we enjoy through policy here in the United States, there are things that can be taken away. It would require lawmakers with enough of a majority to try to repeal the law. And that's true of any law, right? So so there's always that risk. Let's hope it's a very remote one. We'll see what happens in the future.
Okay. And if patients are looking for more information or resources, where would be the best place for them to go?
They should start by using our website, maindeathwithdignity.org, and just hit the contact button. That email will come directly to me, and we'll figure out how to help.
Awesome. Great. In your opinion, is there any possible ways that the law could be improved?
Boy, that's a big question. So this legislative session, we have a bill in to amend the law to allow physicians to waive the waiting period. So one of the things that Maine tracks in their annual report is the numbers of people who enter the qualifying process, but who die before they complete it. So we can show that there are people who should be qualified, and their bodies just don't last long enough. In those instances, once this bill passes, their physician could waive the 15 days, waive the 48-hour period, and write that prescription immediately. There are certainly other ways it can be improved. The challenge is that here in the United States, our processes right now are incredibly conservative on this issue, and you have to have wow, we're going to need a couple of generations, I think, to get to anything different than what we have right now, because the lay of the land is so incredibly conservative on this issue.
Okay, thank you.
Mm-hmm.
One other thing that I will mention as I give some more time for more questions to come through, if there are any, once the webinar ends and the webinar window closes, there will be a survey that automatically pops up for you. It's just 4 quick questions, and we do ask that you take the time to answer those questions. It helps give us valuable feedback and plan for future programming as well. So we would greatly appreciate your time on that. And I'm not seeing any more questions come through, Val. So I think we will end it at that. But as I mentioned in the beginning, this recording will be posted to the Redington YouTube channel. So please share, watch it back as well. And please utilize the Maine Death with Dignity website that Val mentioned.
Thanks very much, folks. And if a question does occur to you afterwards, feel free to contact me via the website, and I'll be happy to help you with that.
Wonderful. Thank you so much.
You're most welcome. Have a great evening, everyone.